Well, thank you very much, and also to just to say it's great to be back in Berlin, such a beautiful city, to see so many friendly faces again, and it's been a pleasure to work with Professor Blumer in terms of helping to develop this meeting. I'm really excited to be able to be here, as I said, and also to talk to you about really an area that is changing rapidly, and that is the post-CDK4/6 space. And as Professor Blomer mentioned, with a real focus on the antibody-drug conjugates, my focus is actually going to be stepping back a little bit, and we're going to be looking at some of the other targeted therapies in this space. And I think, however, before we talk about post-CDK4/6, we have to talk about CDK4/6. So if you're going to think about what strategies to use following a CDK4/6 inhibitor, well, it actually doesn't matter which CDK4/6 inhibitor do you start out with. We're going to be talking about some of the questions that are coming up. For example, one of the things that has really been at the heart of what I think about on a daily basis when I see patients in the clinic is hormonal sensitivity even retained following a CDK4/6 inhibitor? Professor Blomer talked to you about the role of continuing CDK4/6 inhibitors. I'm going to just briefly touch upon that. We'll talk about the space with regard to ESR1 mutations. I'm going to briefly mention the data with regard to targeting Aurora A kinase with the drug alisertib. Well, I won't spend too much time talking about the PI3 kinase AKT pathway, again, because Professor Blomer mentioned that. And then I'm not going to talk about a few other areas. There's really a number of new targets that are coming forward. Certainly the CDK2 inhibitors, CDK2, 4, and 6, are really a promising class of drugs that are moving forward. I won't have time to go over that, and of course the antibody-drug conjugates. So here is the sort of what I call the cutting-edge 2019 pre-pandemic. This is where we saw all the data with regard to Paloma-2, MONALEESA-2, and MONARCH-3. And the data, when you looked at the PFS, if you look at all these curves, were essentially equal. And everybody said, well, these data look exactly the same. Simply, you can choose whatever CDK4/6 inhibitor you want. It's a dealer's choice. Maybe you can choose it with regard to toxicity, because these drugs have different toxicity profiles. And you can see here, when you simply look at these cross-trial comparisons, they look remarkably similar. What's interesting is certainly the control arms performed relatively similar, with a median PFS somewhere between 14 to 16 months in all these trials. However, this slide really goes through and tells you that actually something is actually going on that is actually not mirroring what we saw with PFS. So in Paloma-1, Paloma-2, and Paloma-3, we see no improvement in overall survival with the addition of palbociclib to endocrine therapy. But in contrast, very consistently in every study that's actually been done with ribociclib, we see a very consistent improvement in overall survival. We have thus far incomplete data with the drug abemaciclib. With the first trial that was reported out, MONARCH-2, George Sledge reported an improvement in overall survival. With the MONARCH-3 data that has only been reported out last year at ESMO in terms of the second interim analysis for overall survival. And there what we saw was that there was a numeric improvement in overall survival, but it didn't meet the criteria for statistical significance. And that's simply because that was the second interim analysis and not the final overall analysis. So where we're at this is, I think, very important to understand this landscape, but it's also important to understand, well, how do these drugs work in the adjuvant setting? Well, we know that palbociclib did not improve invasive disease-free survival or really any breast cancer endpoint in the two adjuvant trials. The MONARCH-E, as you know, was a positive trial. And just a few weeks ago, there was a press release, and that is regard to the NATALEE trial, which was reported to be positive. So now what we have is we have this consistency, and that consistency is consistent improvement in overall survival with ribociclib and abemaciclib, again with MONARCH-3 still data pending, and now we're seeing similar findings actually in the adjuvant setting. So I just say in this point, this is one of my strong points. Some people disagree with me, But there are only 2 drugs that have improved overall survival in the metastatic setting. And as it turns out, that's actually still the gold standard. In fact, I was looking the other day at the NIH. The NIH says that they have a moonshot approach program, and you all know about that. And their goal is to reduce breast cancer deaths. So when we're giving drugs, we want to actually give a drug that's going to improve overall survival, and we certainly have choices there that we can use to improve overall survival. So the next question comes up then, in the post-CDK4/6 setting, is endocrine sensitivity or hormonal sensitivity maintained? And I would just caution here that most of these data are in the setting of palbociclib. Palbociclib was first approved in 2015 in the FDA. And so the approvals came later for ribociclib and abemaciclib. We have very few data on the role of single-agent hormonal therapy post-ribociclib and post-abemaciclib. I'm going to bring up this trial. This is a trial that I ran studying a drug called endoxifen. And in this trial, we compared endoxifen to tamoxifen in patients who had endocrine refractory disease. This was a negative trial. The trial actually comparing endoxifen versus tamoxifen, endoxifen did not improve median PFS. But this was my first observation to observe this. In patients who had prior CDK4/6 inhibitor, who progressed on a CDK4/6 inhibitor, we saw miserable PFSs, somewhere in the range of about 1 to 2 months. Now, in patients that had no prior CDK4/6 inhibitor, we actually saw what we expected, which was an improvement in median PFS of about 5 months. That's what this study was planned for. So when I saw these data, I was really perplexed. And I said, well, is that really true? Well, here are the data. I show the lines trial up above, where we see a median PFS of around 2 months. But in SOLAR-1, there was actually a small subset in there that had progression on a CDK4/6 inhibitor, and the median PFS was 1.8 months. Veronica, fulvestrant, median PFS 1.9 months. Emerald, median PFS 1.9 months. Do you get the idea? It looks like endocrine sensitivity is lost following progression on, at least in this case, mostly palbociclib. So the question, of course, is why? Why is endocrine therapy sensitivity lost? We don't know, by the way, and this is certainly something that is of interest. But it's also very important to note that we have to generate data post-ribociclib and post-abemaciclib, because the question here, of course, is, do we see this same observation? In other words, with palbociclib, we see a marked improvement in progression-free survival, but when you stop the drug, that benefit is lost. Well, in contrast with ribociclib, that benefit is maintained. So is it possible that with endocrine monotherapy, which is generally very easy to give, and our patients have very few side effects, do we see better or more prolonged PFS in that situation? Well, what about the role of continuing CDK4/6 inhibitors following progression on palbociclib? Professor Blomer mentioned the MAINTAIN trial. I'm not going to spend a lot of time on that, only to say that this really obviously it was a positive trial, small trial, randomized phase 2, probably not practice changing. We wanted to see some of the next data, and the next data that was presented was at San Antonio, and this was the PACE trial. And in the PACE trial, patients who had progressed on a palbociclib-based regimen were randomized to fulvestrant alone, fulvestrant plus palbociclib, or a combination with a checkpoint inhibitor. You can't really see this, and again, I apologize because the screen, this is fairly small, but bottom line was there is no improvement in median PFS with the addition of or continuation of palbociclib along with endocrine therapy post-CDK4/6 inhibitor. So I think the summary here in this space is that right now we can say there's no role for continuing palbociclib following progression on single-agent palbociclib. We see a small benefit with MAINTAIN. And I think what we're kind of interested, not kind of, very interested, is, well, what about abemaciclib? Well, we're going to get some data with abemaciclib from a number of different studies that are going to be reading out. I'm going to mention ELAINE 2 shortly. The post-MONARCH trial, which is being led by Kevin Kalinske, is comparing abemaciclib plus fulvestrant versus fulvestrant alone. And then the ELAINE-3 trial is a trial that will be starting hopefully later this year, an FDA registration trial of fulvestrant plus abemaciclib versus lasofoxifene plus abemaciclib. So let's go on to the next part of the talk. I think I have like 4 minutes left. It was gone by so quickly. What about these ESR1 mutations? And I have to be careful because I look across in the audience and I see some incredible experts in the field here who know this area more than anyone here, and that would be Professor Osterreich. But certainly ESR1 mutations are not just something that are, yeah, we see them, but they're actually clinically important, and they represent an important target. These mutations confer endocrine insensitivity or reduced sensitivity, and they are common. So we see them in the metastatic setting as a result of, certainly we see it more commonly in patients that have been treated with aromatase inhibitors alone or aromatase inhibitors in the setting of CDK4/6 inhibitors. Well, there are a lot of anti-estrogens in clinical development, and you can see a whole list of these. This was a list that I put together from I received from one of my colleagues, and I've made some edits over the past year or so. But from this list, you can see that there are anti-estrogens that are being crossed out. That is, they're no longer in development. But there are still some very important ones here. Camizestrant, for example, immunolestrant, elacestrant, giredestrant, Z-endoxifen, lasofoxifene. Well, what about the EMERALD data? You know that this drug is now FDA approved. It's been approved actually only in patients with the ESR1 mutations. And again, what you can see is a relatively modest improvement in median PFS. But as Professor Blomer said, and in an unplanned analysis that was presented last year at San Antonio, it seemed that the benefit was greater in patients that had longer periods of time on prior CDK4/6 inhibitors. Well, what about camizestrant? This is a drug that's being developed by AstraZeneca, and this oral SERD looks very promising. This is data from the SERENA-2 trial that was presented at the San Antonio Breast Cancer Symposium. This was a dose, looking at several different doses, and the bottom line is that this was a positive trial. That is, camizestrant improved median PFS from about 3.7 months with fulvestrant alone up to about 7 months with camizestrant. One of the things you can see here in this trial is in patients with prior CDK4/6 inhibitor, you can see there was benefit. Notice again, you can see if I made my point, again, median PFS, fulvestrant, 2.1 months, post-CDK4/6 inhibitor. But you can see that camizestrant actually here was more active. In patients with no prior CDK4/6 inhibitor, there really didn't seem to be much of a difference between these two different drugs. What about ESR1 mutations? Here you can also see that in those that with detectable ESR1 mutations, there was a significant improvement. Here again, you see that median PFS with fulvestrant of about 2.2 months. Well, let's move on in the last few minutes and talk a little bit about SERMs in ESR1 mutated breast cancer. I'm excited because I think there is going to be a revival of SERMs. You know, we go from the what I call the older era where you treat 15,000 patients with one drug and you compare it with another 15,000 patients and you say, there's a slight improvement in PFS or, IDFS, and so therefore all patients should be treated with that one drug. And the reality, of course, is that what our patients need is they need multiple options, and we need to bring forward the most active drugs because not all patients can tolerate tamoxifen, not all patients can tolerate aromatase inhibitors, not all patients can tolerate fulvestrant. So this is a really exciting era where we can develop more drugs and hopefully active drugs for patients, not only in the metastatic setting, but in the early stage setting. Here you just see some data that would, this is in a preclinical model. These are breast cancer cells, SCIBR3 cells that are ER negative, HER2 positive, and they've been transfected with an ER reporter gene construct, and just showing the fact that these, using this particular model, that some of these drugs actually are relatively insensitive or do not work as well in the presence of these ESR1 mutations. Here on the right-hand side, you see that the drug lasofoxifene actually is able to potently bind the Wi-Fi3/7S mutation and actually lead to its inhibition. And so that really what led to the development of this drug, lasofoxifene, as a drug. I presented these data at ESMO this last year. I'll quickly go through that. Lasofoxifene versus fulvestrant, again in the post-CDK4/6 setting in patients with an ESR1 mutation. This was not a positive trial in the sense that it was not statistically significant. But there was a signal with this drug. For example, lasofoxifene improved median PFS from 4 to 6 months. And you can see PFS at 6 and 12 months. And there were a higher response rate in patients treated with lasofoxifene. And you can see that here on the fulvestrant on the left and lasofoxifene on the right. Really not much in the way of side effects, but one of the things that was really interesting, and that is the Y537S mutation with fulvestrant. In patients who had this mutation, by the way, it was a stratification factor. Lasofoxifene, the median relative change for all variants was about an 87% reduction, whereas fulvestrant, there was a much less robust median change. And actually, if you look at the median relative mutant allele fraction, there was actually an increase with fulvestrant with this particular variant. So there was also another trial comparing lasofoxifene plus abemaciclib, and I'll just mention here that this drug also, this combination appeared to be quite active, response rate of 50%, which was really quite outstanding in patients with ESR1 mutations. And this is ultimately leading to an FDA registration trial combining lasofoxifene plus abemaciclib. I'm going to finish right now. I know I'm over. I'm taking advantage of that extra couple of minutes here, but I'm just going to finish with this, and that is there are many other pathways we don't have time to discuss today that are important. I did want to mention this. This is actually a drug and a trial that was being led, that has been led by Dr. Haddad, who's in the audience. She'll be talking a little bit later today. This is the drug alisertib, which is an aurora kinase inhibitor. And this particular drug, as you know, was developed as a hematologic drug. When Dr. Haddad ran this phase 1 clinical trial actually a few years ago at her center, we saw some really profound anti-tumor activity. And this ultimately led to this phase 2 trial of alisertib alone or combined with fulvestrant in patients with endocrine-resistant disease. And in order to get onto this trial, you had to have progressed on a CDK4/6 inhibitor. The bottom line was this drug provided evidence for anti-tumor activity with a response rate of about 20% in each arm. And the duration of response, there were some really profound and prolonged responders in this particular trial. You can see a median PFS of around not quite 6 months. Here you see the waterfall plot with both arms, and certainly this drug is active. And based on this trial, this drug has actually now been taken up by Puma Pharmaceuticals, and they are moving it forward in breast cancer, metastatic breast cancer that's hormone refractory. I'm going to stop there, and I just want to leave you with this slide. This is the evolving treatment landscape of hormone receptor positive advanced metastatic breast cancer. It's amazing if you go from the 1970s to around 2002, we had very few drugs approved, but things are beginning to rapidly change now, and this is such good news for our patients. You can see on the right, elacestrant recently approved. We hope capivasertib will be approved soon, and a number of other drugs that are behind it. Thank you.